Yeah,
Yeah,
no,
the exercise, the idea I bought exercise because of interleukin 15,
that was
which is,
that was just a
yeah,
entertainment.
I know, but the reality is that the trigger of the exercise is the interleukin 15, which is Dr. Patrick Soon is talking about. It enhanced the natural killer cells. And so I start looking at how I can get interleukin 15, your body producing it. Same like Clotho, how we can get our body to produce it. So I find out the more muscle you have, the more active you are, the more interleukin 5 you have. And most of patients with cancer, they're putting them in the chair and giving them IV fluid, and they are getting atrophy without thinking, oh, well, we need to get their muscles toned and large. And if they cannot exercise because of the fatigue or whatever, we can at least do it passively through electrical stimulation, which is muscle electrical stimulation, and still we can secrete clotho and interleukin 15 and boost the natural killer cells to kill the cancer. And that's the whole idea is the interleukin 15 trigger the idea of activating the muscles, whether it is exercise, which is better stress exercise or resistance exercise, or electrical stimulation. So that's the reason I was looking at the way to get the muscles big and fat, to get the fat less, in order to increase interleukin 15, which help to enhance the immune surveillance and preventing us from having cancer. And so people with big muscles and less fat, they have less risk of having cancer versus a person who has atrophic muscles or less muscles and more fat. And so it's part of cancer prevention, cancer management is to get the big muscles by all means, whether it's stress exercise or electrical muscle stimulation. And so, but as I said, some people they cannot. So if they can't because of the fatigue, then they can do electrical muscle stimulation, which we know either way to get this clotho and interleukin 15. But the life we live, the lifestyle we live, which is sitting in a table and in the car and less walking and all that stuff, it's really encouraging atrophy of muscles and getting fat. And when you have too much of fat, you end up converting all your sex hormone into estrogens. And when you have estrogens high, and then you have insulin resistance, which is insulin high, then this both are growth factor drivers, and that can lead to all the problem that we have, inflammasome, senescent cells, cancer cells. So it's part of the management of cancer to get your muscles toned and large. So that's why the idea of clinical gym come up as part of the clinic, because the only one I see that he does clinical gym is Dr. Barr in California and Dr. Stefan Hartman, and they're both are very successful doctors. But anyway, the topic today, I'm Dr. Halasa, the founder of Chronic Disease Prevention Management and Systems Medicine, which I patent systems medicine as an education with USPTO. And we want to talk about this big problem that we have, which is uh, uh, to a group, mainstream medicine, along with their specialist, and then integrative medicine and systems medicine about LDL and cholesterol. You know, a lot of integrative doctors they see cholesterol. It's high. It's good. It's healthy. Don't drop it. Don't work on it. We need high cholesterol. So they don't see it at all. They see it as a normal thing. And they start putting a stigma for any integrative doctors trying to lower the cholesterol. And then we have the other side of the mainstream medicine. If they have little cholesterol high, oh, that's danger. That's going to goes atherosclerosis. Patient's going to die. And then you have this big fight, big conflict between both sides of diet. So what's the truth? And that's what we're looking for. And the truth is that there is bad cholesterol, and that needs to be lowered, but in a form of Apo B, numbers of Apo B, not mainly the concentration of cholesterol, but more about the number of the particle that carrying this cholesterol. And we're going to see the difference between concentration of cholesterol versus, which is the total cholesterol, versus numbers of ApoB. Because if you have a normal ApoB particles, less than, you can say 80 or 60, some labs they say less than 60, then uh, and you have high cholesterol, total cholesterol, but normal ApoB, what's that mean? You have normal numbers of cargoes of trucks carrying cholesterol, and yes, those trucks are full with cholesterol, which is fine. Um, but as long as the numbers are less, you have less risk of having atherosclerosis. But if you have too much of cargo, too much of trucks, and those trucks are carrying less cholesterol, even normal cholesterol, of course, if high cholesterol, even bad, then the high ApoB is the problem because those particles will end up depositing into the blood vessels. And to make sense out of this, I don't know if somebody here traveled to Germany, but in Germany, the roads are very narrow. And when they have trucks in the road, it's gonna block the road and you're gonna have traffic in Germany. So the trucks is causing the traffic in Germany. And the less truck you have, the more that the road is open and you can drive fast. The more truck you have, the a problem, you have congestions. And so the same thing here in our body. The more particles that carrying those cholesterol high, the more risk we're going to have atherosclerosis. So the whole idea is that now is being shifted from just measuring the cholesterol, which does not give you any relationship, or it's not that much related to atherosclerosis. More, it is the number of the cargo carrying those cholesterol. And the more numbers you have, the more risk of depositing those particles into the blood vessels. And so that's the whole idea because cholesterol they will be carried in those cargo. It's not like free floating there. But if the cargoes are too much and your liver cannot pick them up and clear them up, then those cargoes, which is the ApoB particles, along with cholesterol, they will be start depositing and causing the atherosclerosis. So now we need to take ApoB serious. Both the mainstream medicine needs to change from idea of high LDL cholesterol or high total cholesterol into looking at the particles, not the cholesterol, the cargo, the carriers, and the numbers of the carriers. Because if you have high cholesterol, but you have low trucks there on the road, it's fine because it can be cleared and it's done. But if you have too much of particles there, then the liver have a hard time to pick them up because the liver, how the receptors work, they take the whole cargo in, not just one piece of cholesterol in. So the number of the cargo is determining the atherosclerosis risk, not the total cholesterol. And that changed the whole idea of management atherosclerosis. And so the mainstream medicine needs to consider ApoB level, and also the integrative doctors, they have to open their eyes and they need to work on lowering the ApoB, lowering those particles. And throughout this lecture, we're going to talk about the biology of ApoB, the structure of it, the metabolism, the risk of atherosclerosis, and the clearance of it. We're going to talk about measurements, lab testing, and we're going to look at the root cause because the high ApoB can cause by many reasons. It could be primary or it could be secondary. What's the meaning of primary, secondary? Primary means there's genetics involved in increasing the ApoB. And secondary, it could be because of secondary to insulin. There's insulin resistance and high insulin. That can cause, because insulin stimulate the production of triglyceride and production of ApoB. So insulin resistance, or it could be you have liver disease where you don't have you have problem with excretion of those bile and getting rid from this extra fat, or you have a problem with your kidneys with excretion, or you have too much absorption, like you have genetically anomaly or a genetic problem where you absorb too much of fat. And also that can lead to increase the ApoB. And then we need to consider when we manage them, manage high ApoB, we don't just give them statin, right, all over. We have to look at the root cause. Is it because of insulin? Is it secondary or is it primary? And is it because of genetics? Can we work on looking for drugs that inhibit those genetics? And if it takes us to give a statin at the end of the road, then we may need to give it. Although a lot of integrative, oh no, statin can lead to uh, compromise the mitochondria, and that's true. Statin can lead to a myocyte inflammation of the muscles and breaking up the muscles. All of that's true. But then we're gonna check the advantage and disadvantage, and we go from there. So I am the guy or the doctor in the middle. I'm not a savvy integrative, not a savvy mainstreamist, but I'm looking for a drug better than statin to increase the production of LDL receptors because statin. The reason it's still there because it increased the LDL receptors. Now, if there's any alternative drug out there that increase LDL receptors, which may be some out there, but then without the side effects of statin, that would be great. So, but up to now, we
Think,
don't have that.
what
Um,
about Dr. Halasa? What about Amlexinox? Because I don't know about the receptors, but I do know that I think it was Dr. Sylvan. He had a dramatic decrease in his LDL.
right, Apo B, but amnoxidant, that's possible. So, amnoxidant maybe helps to increase the expression of LDL receptors. Um, but amloxanox does help in insulin resistance. So it depends on your ApoB. Is it because of insulin driven or it's because of genetics? And that's where we need to make all the studies because me and Dr. Stefan Hartman in the challenge there, where he said uh, ApoB has nothing to do with insulin and ApoB is genetics, and that's why he's taking statin for it or taking other drugs that helps to lower the ApoB. But what I can say is that insulin resistance does increase the production of ApoB, and also it increases the production of triglyceride. Because when you have insulin resistance, then you know the body cannot use sugar, so they start breaking the fat, and the fat tissue releases triglyceride, and then the liver has to deal with it. So they start producing high, very low density lipoproteins, which contain ApoB, and that's the reason you end up with insulin-driven increased ApoB or insulin-driven ApoB high. It's you will find out that the triglyceride is high and the ApoB is high. So you have two. But when in genetics, most of the time, or non-insulin driven, you will find normal triglyceride and high ApoB. Then that's not really insulin driven. That's mainly it's because of those genetic or other secondary causes, maybe liver problem. But insulin driven, most of them they have high triglyceride and high ApoB, and then non-insulin driven, they will have high ApoB and normal or low triglyceride. But there's a lot of other testing to know exactly where is the problem. Is it a problem for absorption of too much of fat? Is it the problem of genetically problem with LDL receptors? Is it a problem with excretion? There's a lot of genetics there. And that's where you need to go and do the genetics so you can know the cause. And then based on that, because if it's a problem with absorption, there will be a drug that can help the absorption of the chylomicrons and absorption of those fat. But we're going to see that all in the coming slide here. As you see that when we eat fat, and I don't recommend, so I have a lot of doctors that I met in California, and he was against keto diet. He say, we cannot have buffet of eating fat and say, this is a healthy thing. Well, the reality is that most of the time when you eat fat, you easily get satiety, so you get full and you don't eat a lot. But some people they end up having this a problem with the satiety, and they start saying, I'm eating keto when I can eat all this fat, and some integrative doctors are promoting fat food like unlimited. My advice is that there's nothing is called eat unlimited, whether it is fat or non-fat or low carb. It's one diet a day. That's supposed us as humans, one lunch a day, one meal a day. That's supposed to normal. This idea of breakfast, lunch, and dinner, this being pushed by the commercial and being pushed by those people who wants to make money so they can sell you all the food. But we normally, as humans, we need to start thinking of eating one meal a day. And we need to consider also not to eat like 12 hours, not to put anything in our mouth except water. And that helps to activate the the phagocytosis, the autophagy, to kill those cancer cells and senescent cells and inflammasomes. So we need to give that space for the for destroying or activating the autophagy. And I will go with fasting 1 time a week, just drinking water along with your multivitamins and medicine, whatever you take, so that we can fully activate the autophagy and mechanism and kill all those inflammasomes, senescent cells, so we can feel healthy and we lower the risk of having cancer and we activate the natural killer cells. So that's what I recommend. So when you eat fat, and what will happen, how absorb it through chylomicrons. Now, chylomicrons, they're also a pack of lipoprotein. They call them Apo B48, but they are bigger in size, and Apo B48 is not considered as Apo B100 because it does not have that positive charge and size is big. So basically, it does not cause atherosclerosis risk most of the time. So it's not being counted as chylomicrons as part of the counting of the ApoB. Only the ones that contain ApoB 100, that's atherogenic particles, which include very low density lipoprotein, low density lipoprotein, and intermediate density lipoprotein. Those one carry the ApoB 100, they're positively charged. And when you have too much of those cargoes in the blood vessels, not the concentration of the cholesterol and the LDL, but the number of the cargo, which is the ApoB, which that's how you count them, because each particle has an ApoB on it. But what we need the ApoB in, it helps in attaching the particle to the endothelial cells, so the endothelial cells can get it in, or helps in attaching to by endocytosis to the liver cells, so you get rid from this extra LDL. So what happens is that when you eat fat, it will be degrade by the bile, and it will be absorbed through the bile into through chylomicrons, which is a particle that contain ApoB48, and then that will deliver some cholesterol, the chylomicrons, to your blood vessels, and then eventually it will end up in the liver. The liver will degrade them and then load them into a new truck. It's called very low density lipoproteins, and then secrete them. And then very low density lipoprotein will be picked up by your blood vessels of your muscles and fat and whatever organs of your body, and start causing breaking down of those very low density lipoprotein with lipases that's in their surface. And then it convert into intermediate density lipoprotein, and then still you start degrading it, releasing the fat, and eventually they become a low density lipoprotein. So they are truck carrying the food to your body, and then once the LDL is too much there, your liver say, okay, we need to get rid from this extra food delivery because nobody needs it. So the liver would pick them up and then dump them into bile and excrete them, right? So that's the cycle of the whole process. Now, in this cycle, you will end up having problems, whether problem is metabolic, secondary or primary. Secondary, maybe you have fatty liver and liver problems where you don't excrete the bile. Then you have too much of LDL circulating and ApoB high. That's a problem. Or you have problem with your kidneys and they have problem with secreting, or you have problem with your metabolism, which is insulin resistance, and insulin resistance leads to increase the production of ApoB. It leads to increase the fatty acid that's being released from the fat going to the liver. Yes, so the liver will respond by producing too much of very low density lipoprotein, the hepatic ones, and that contain ApoB. Yes, and eventually they will have high ApoB, but also you'll have high triglyceride, which distinguish it from other high ApoB induced root causes that we're going to talk about, genetic or environmental. So here we understand that those particles that contain ApoB is very essential because the way that it attaches to the receptors and getting it in, whether into the liver or into the organs. But those ApoB also a protein, they're positively charged. Once they've been trapped inside the blood vessels lining or beyond the endothelium that lines the blood vessels, they get stuck there, and then they'll be digested by macrophages. They get oxidized, those LDL, and then they become a fatty plaque of foamy macrophages containing fat. and they start growing up. And then this inflammation can lead to fibrosis. And then this inflammation will lead to calcium deposit. So you have, a combination of calcium deposit, fibrosis, and inflammation and fatty plaque. When you're treating atherosclerosis, it's not just enough to dig into those fat and getting them out by cyclodextrin, but also you need to dig up the calcium by EDTA, and also you need to look at something that helps with fibrosis, possibly the bromelain and lumbokinase, but also maybe losartan. So you need to give some antifibrotic or clotho. Clotho is a good one. Clotho is antifibrotic. The reason why we are growing in age is because our clotho drops. When clotho drops, your fibrosis goes up. And we know that fibrosis will replace your parenchyma of all your organs, and with time, your body will become fibrotic at the age of 100. And that's why we die, right? So this speeding the process of fibrosis is because of the drop in the clotho. And so we need to do anything that increases clotho, including exercise, big muscles, lower fat. That helps. And if it takes to give some external clotho from outside, I'm happy with that too, so that we can reduce the fibrosis that leads to atrophy of the parenchyma and aging and death and failure of all the organs. So that's part of the anti-aging. So now we understand what is very low density lipoprotein, intermediate density lipoprotein, all that. And then we have this high density lipoprotein. Those are a trash cargo. They carry all the trash from the bloodstream and also from the blood vessels, similar to cyclodextrin. There's a similarity between high density lipoprotein and cyclodextrin, by the way. So this is the trash truck going and cleaning up the trash and then putting it back to the liver. So very low density lipoprotein, intermediate, and LDL that has Apo B on them. They are a food delivery truck, right? And we don't want too much of truck on the road, because you end up with traffic, you end up with atherosclerosis. You need less of those traffic. And it's fine if those cargoes full of cholesterol. That's fine, even if you have a little bit high cholesterol, but you have normal Apo B. That's mean you have number of the cargoes. It's okay. So that's good. But if you have too much of cargoes, then you have traffic, and then you have this atherosclerosis. So that's the whole thing. And then the high density lipoprotein, the Apo, it's Apo A on it, and they are not sticky or trapped in the blood vessels like the Apo B100. And their job, this Apo high density lipoprotein, is like a trash car or truck that carry the trash in the morning. That high density lipoprotein does the same. So cyclodextrin does the same thing like high density lipoprotein. So if you have a low high density lipoprotein, or you have atherosclerosis already been established, maybe because for a long time you did not use your thyroxine, and thyroxine is very important because low thyroxine means high Apo B, and you end up having all this atherosclerosis there. So your thyroxine needs to be fixed. Your liver needs to be fixed, because if you have hypothyroidism or fatty liver, then you have high risk of Apo B. Then you have this atherosclerosis in your blood vessels, and it becomes fibrotic, calcified, and it's hard to reverse. Don't think about, oh, I'm going to give them statin, it's going to be reversed. No. You need to do all the treatments to really get those blood vessels. And at the end of the day, exercising helps to grow new blood vessels, and possibly those new blood vessels will bypass those atherosclerotic blood vessels. So exercise helps to create those bypasses that you need to bypass those blocked blood vessels. But if you don't, then you will be having, and you will end up having hypertension, and you will end up with all this problem that we know about stroke and cardiac angina and all that stuff. So we want to prevent that, and we want to come up with a management to prevent the increase of Apo B, and also to clear those atherosclerosis, those fat and atherosclerosis, the calcium and the fibrosis from the blood vessels. And we need to come up with the realistic protocol, and we need to optimize the body health, and we need to increase the clotho in our body to reduce the fibrosis and atherosclerosis in the body. So muscle activation of muscles and exercise, it's part of healing atherosclerosis. Whether the exercise helps to increase the muscles, that increase the insulin receptors, that increase the sensitivity of insulin, that will drop the Apo B secondary. Or increasing the muscles helps to increase the blood vessels, and that would bypass the whole obstructed atherosclerotic blood vessels, the narrow blood vessels. Or this exercise can increase the clotho, and that decrease the fibrosis. So exercise is it's very part of our healthy life, and we need to be part of it. And if you can't exercise, you do muscular stimulation of the muscles. That helps as well. It's not like resistance exercise, but it's better than nothing. And that's the whole thing about Apo B. Eventually, those circulation of those Apo B, they deposit into the blood vessels, and they cause the macrophage to eat them, causing this foamy macrophages, inflammation, causing calcium deposit, fibrosis, and all the things that we talk about. So we need to go ahead and come up with a protocol that breaks the fibrosis, that detox or chelate the calcium, that get rid from the extra fat, and we have the program for that. We have the protocol for that. So what would happen when those food delivered excess, too much that your body does not need? You don't want them to be staying around there, those apple, because they're toxic, right? They can be buzzing your blood vessels and causing problems. So your liver will go ahead and pick them up, but they have to have the pickups for those cargoes. And they have what's called LDL receptors. But sometimes those LDL receptors numbers decrease for some reasons, genetic, for example. So if that's the case, then patient can have familial hypercholesterolemia and high Apo B and atherosclerosis. So we need to look at how we can increase those number of LDL receptors. Insulin also, when it's high, insulin resistance can lead to decrease in LDL receptors as well. And genetically also. So the only treatment we have that currently that works is us improving insulin resistance. That's part of it. So you can remove one of the drivers, and treating the fatty liver by all means, so you can get the liver functioning and getting rid from all this extra fat and extra LDL receptor. Yeah, that helps to gain the LDL receptors. Or we give them statin. But if there's any drug that increases expression of LDL besides statin, I need to look at it and see if we can integrate it in our program. But again, sometimes if everything does not work, you have fasting insulin is normal, you look healthy, like Dr. Stefan Hartman, and let's say he still has Apo B, then sometimes he has to go to the next step and take those statin. But again, he needs to take it with all the other supplements that counteract the side effects of statin. But there are some drugs that inhibit or increase expression of LDL out there. You can try them. We're going to see them in the coming slides. But if it does not work, maybe you need to combine them with statin. So see, integrative doctors, they're not happy with me, which is fine, because I mentioned giving statin. But again, I don't give it to anybody. First of all, I work on insulin resistance first, see if we can lower it. That will be along with triglyceride. And if there is everything we done, if the problem with absorption, then there's a drug that helps to decrease the absorption of the fat. So we don't need to use statin for those cases. We're going to see those names of drugs, those sterols. Sterols, they can be absorbed, those fat, especially the fat coming from extracted from the plant seeds. Those are very dangerous. They contain a lot of sterols. And we need to stop them, and there's blockage for that, of those absorption of the fat. So, it depends on what is the cause of your high Apo B. If it's kind of absorption, we have a drug to inhibit that, and we're going to see that in the coming slides. But with increased expression of LDL receptors, we don't have much except statin, plus other things, but it may not work too much. And so there's drugs that inhibit the PCSK9. When you inhibit that, you increase expression of LDL receptors. So there's drug for that, but again, statin does inhibit that as well. Plus, there's other drug, and sometimes that other drug does not work, so you may need to get them all. So the PCSK9, that's a target that we can inhibit it to increase the expression of the LDL receptors. And there's researchers now that are trying to develop those drugs to inhibit the PCSK9. A statin is one of them, but there's many others that they're working, and hopefully they find out a drug that does not have the side effects of statin in the future. Measuring Apo B, Now, Apo B is everything. Very low density lipoprotein, LDL, intermediate LDL, and then the remnants of it. When they break down those LDL and very low, when the process of breaking it down, because your body blood vessels, they have lipase, they break down the very low density lipoprotein into intermediate, and intermediate gets into LDL, and then there's remnants of it. And there's also something that's called lipoprotein A, which is very dangerous one that is also included there, that has very atherosclerotic effect. And if you want to go dig deep and you say, I want to measure that lipoprotein A, then you can. And if it's high, it's a problem. But you don't need to go to the expensive thing. Just go ahead and measure that will be, and it will be included. So all of this have atherogenic effect, those particles. And so the idea of total cholesterol before LDL, total cholesterol, and all that stuff, you don't make your management based on that, because you may have normal, or you may have high total cholesterol and normal ApoB. I don't bother to manage that. Okay, I sound like now going with integrative medicine there, but when what's alarming when the ApoB is high, then I need to know the cause of it. Is it because of the secondary ones that I can manage and modify? Yes, if it's because of the primary, then we need to look at drugs specifically for that primary ones. It could be genetically that leads to absorption, too much of excessive absorption of fat. I can block that, or LDL receptors being the expression of it's being decreased. I can increase it, or the problem with excretion. So I need to look at every root cause and start managing it accordingly. Um, so again, what's the problem here is ApoB when it's high, and ApoB could be caused by insulin resistance, so fasting insulin is part of it. And especially if you find triglyceride is high and ApoB is high, consider that is caused by, mostly but caused by insulin resistance. Does not mean that 100%. In medicine, sometimes there will be some genetic background there. You may consider it as well. Okay, so LDL cholesterol versus LDL high up ApoB. And when you have a patient with relatively low ApoB, and let's say he has normal or high low density lipoprotein, he's still more healthier. See the cargo numbers there, the traffic. There's not much traffic because all this cholesterol is being packed inside those cargo, right? So this guy has less risk of having atherosclerosis than a patient has high ApoB. Even with normal cholesterol, but has high ApoB, it's a problem. All right. So if you have low density cholesterol, low or normal, but you have too much of ApoB above 80, then we have a problem here. So that's the reason now we need to be really thinking about measuring ApoB, because you may have low cholesterol or normal cholesterol and you say he has normal cholesterol. Why he has atherosclerosis? Well, because he did not measure the ApoB. Now we know that important is ApoB, the number of the truck. And I gave you an example in Germany. The traffic is caused by those truck, right? It's not by what's containing the truck. Right? It's the truck itself. So the whole number of ApoB is high, even with normal cholesterol. Then that's a risk. But if you have high cholesterol and normal ApoB, it is less risk of having atherosclerosis than when you have ApoB high and LDL is normal or low. Does that make sense? So it's all about the number of the particles, not the concentration of the cholesterol in the blood. And so
I do have evidence
yes.
here, by the way. I was just going through my information, and it looks like beta clotho. Alpha clotho is what really is considered to be what's studied the most, and that's out there available, even though it's not readily available. It's still available through, if you know where the right sources are. But the one thing that's interesting is I'm trying to find out from these formulations if they are including fragments of alpha clotho, beta clotho, gamma clotho, because they seem to make reference to that, but I haven't verified it. But beta clotho is directly involved with fibroblastic growth factor 21, which is a major hub for the metabolic networks, more specifically. Whereas alpha clotho tends to be focused more on signal coherence and some of the more of the calcium, parathyroid, vitamin D pathways, more specifically TGF beta as well. But beta clotho is one that I've been doing deep dives with, and that one, when I go through that literature, it seems like another one of those best kept secrets. Like it's holding out because that one would hit metabolism more than any other clotho fragment, meaning that it would be heavily involved with metabolism and fat burning. And that one actually has direct evidence that it has an effect on the LDL receptor, or you said I'm not sure what the PC, what is it? PC, PCSK9 transcription.
Right.
That
Those
one is
one, when
showing.
it's overactive, it decreases the expression of LDL receptors.
No, I mean, it
So
increases the expression of the LDL receptors, according to, I probably have it backwards, but it's,
I think you got it backward. If you have too much of this activity of PCK9, it decreases expression of LDL. That's why we block them.
yeah, so beta clotho,
Blocks
I'm
the
looking,
PCSK9.
yeah, down
Okay.
regulates, yeah, down regulates the, God, I had it here. I don't want to
Yeah, the
waste time with
PCCS,
it.
it's written in front of us. The
Yeah, and my,
PCSK9. Yeah.
yeah, and
Anything that
my
blocks
apology.
it, that's good. A statin blocks it. If Cloto blocks it, is good. If amloxinox blocks it, is good. There's other drugs that blocks it. Anything that blocks it helps to increase the expression of LDL
Yeah,
receptors.
yeah. It's actually FGF, fibroblastic growth factor 19.
Okay,
I said
good.
21. So that's what it does, and it suppresses the CYP7A1. That so I just want to let you know the other ones I looked at, oxytocin, amlexinox. Technically, mechanistically, there should be some downstream effects, but beta clotho more specifically affects those expressions directly.
Right. So anything that increase the expression of LDL receptors or have the PCSK9, that's what we are looking for, because most of the genetics caused by this problem of impaired clearance. They don't clear this LDL and they got too much of them out there. And could be secondary. That's why you need to check, you don't just give statin. Patients may have hypothyroidism, right? What's the benefit of giving statin? If you fix the thyroid, you're good. Your everything will go normalized, right? Your expression of LDL will go up. So hypothyroidism, kidney diseases, and diabetes as well, insulin stimulates and have the expression of the LDL, and it increases expression of PCSKR in insulin. So you need to lower the insulin as much as you can. Insulin resistance is a problem. Plus, insulin resistance leads to all the fat to release triglyceride, which overwhelm the liver, and they start making their very low density lipoprotein and all those cargoes of Apo B. Um, Anything that blocks the liver bile, the cholestatic diseases, whether it is blockage or sclerosis in the bile or stagnation there, we need to go ahead and move them. Cholestyramine is one of them that helps. And if there's any medication that leads to a problem with expression of LDL receptors or stagnation of the liver, there's a lot of medication out there. It could be secondary. So you need to check all those things and then screen them out and look at the root cause versus giving statin to everybody. And that's what the mainstream medicine does, giving statin to everybody, or the integrative will deny it completely. They say, oh, I need the cholesterol is high. And they have no idea about the Apo B, the oxidized LDL, the small particle of LDL. They just deny it and say it's okay. Just don't inhibit the cholesterol because you will have the sex hormone. And there is a point there because if you inhibit too much of cholesterol, then you will end up lowering the sex hormones, right? And then lowering the sex hormone will lead to oxidative stress and causing atherosclerosis, right? So there is some point there, but at the same time, we have to dig into the root cause. And if we can avoid giving the statin as much as we can, that's fine. But if there is nothing that can help except statin to lower the ApoB, then go ahead for that, because Apo B is an index of causing. And then if they have lowering their sex hormone because of the statin, then you need to go and work on increasing, giving them extra sex DHEA, to just try to navigate the side effect of the statin if you need to give it. Um, until we get a drug, and we say there's some peptides work. So try everything that helps increase expression of LDL receptors and do the statin the last thing you can. If there's any out there, Clotho, if amloxanox, if we find out it helps, it's good. I know amloxanox work through insulin sensitivity and insulin-driven high ApoB, but I don't know if there's direct relationship increasing the expression of LDL receptors. So first of all, make sure that you work on the insulin resistance. That's the first thing. And you know it by if you see ApoB high and triglyceride high, most of the time it's because of insulin driven. But if the ApoB is high and triglyceride is normal low, then must it's because of genetics or somebody else, so something else. So you need to look at the root cause of it. And then you need to know, where is the problem with genetics? Is it absorption? Is it LDL clearance? Is it excretion? Is it secondary to liver disease? So you need to look at all of that. So insulin resistance and high insulin, eventually when the body cannot use the sugar because of insulin resistance, your body will start getting the fat from the fatty acids, or from the fat from adipose tissue. So you have too much of fatty acid. That's why you'll see patient with insulin-driven high ApoB, the triglyceride is high. That makes sense. And then who's going to take those fatty acids? The liver, and the liver will create chylomicrons. Will create the endogenous very low density lipoprotein, right? And then this very low density lipoprotein, they will be turning into LDL. And then you have high ApoB because of that, and all the remnants of LDL and all of this. And then the liver will be overwhelmed, right? Because of the fatty liver itself, right? They get sick with the fatty liver, and they have less receptors there because of that as well. So you get all this atherosclerosis because there's LDL cannot be picked up in an efficient way, and liver is fatty liver, and end up even with the cirrhosis with time. So they don't get rid from the extra fat, and they start depositing in their blood vessels. So managing insulin resistance is the first thing you do. If you want to really work on lowering the ApoB, you cannot say, "Oh, well, you know what? He has to see that this is the disaster, what's happening in the mainstream medicine." For those patients with diabetic, with fatty liver, with insulin resistance, they will start with giving them metformin. And if it does not work, and they don't look at any other causes of insulin resistance, because there are many other causes of insulin resistance. It could be toxins, it could be low sex hormones. They don't see that, okay? That just failed. Metformin, oral hypoglycemics, not working. Let's go give them insulin. So diabetic type 2, their pancreas not failed yet, right? They start giving them insulin to treat diabetes. And then the insulin itself will cause more atherogenesis and cause more clogging of the blood vessels. So this is a disaster, right? They're giving insulin above the insulin that the patient has in insulin resistance. And that's causing more problem and causing more clogging and more complications of diabetes, by the way. And then they say, oh, and then we have high cholesterol. Let's go ahead and give them statin. Right? And then they end up with lower sex hormones, and they end up having all this problems, stroke and that. So because they don't look at the root cause before you give them statin, this high ApoB and triglyceride, it's because of insulin resistance. Work on insulin resistance by looking at all the causes of insulin resistance. If it takes you to give them something for their obesity, if it takes to give them GLP-1 with smart way of giving it, not GLP-1 and only, you have to do all the navigate all the side effects of GLP-1, giving them B12, giving them things that do detox and all that stuff. Start with small quantity if you need, or there's a lot of other things that helps to inhibit the satiety. And then you have to give them everything that increase the insulin sensitivity, detox the body, give them sex hormone. And then that's how you increase insulin sensitivity. And the triglyceride will be lowered by itself through the exercise and healthy diet and weight reduction program, where you don't need to poison them with statin, because here it's very clear that it's insulin resistant that leads to the triglyceride. Same thing, you patient with insulin resistance and they have high uric acid. Well, insulin stimulates the xanthine oxidase, which leads to production of uric acid. And say, well, you know what? You're diabetic plus you have gout. We're going to give you allopurinol, right? Well, the reason he has gout or high uric acid is because of insulin resistant. So manage that. You don't need to give allopurinol. So that's the problem with insulin resistance. It has many complications, including gout, including high cholesterol, all of this, and it can be managed in the root cause before you start, looking at the side or the complication of the insulin resistance. Yes.
Dr. Halasa, I
Yes.
do have some evidence here I think is worthy here. So, because I went through all the peptides that I use, I've got a lot of information that I have to go with. And the strongest peptide-related signal, according to this, is FGF21 beta-klotho. I guess it is FGF21. I know we haven't really learned the fibroblastic growth factors, but I think we should. FGF21 requires beta-klotho as a co-receptor. In experimental models, FGF21 treatment has directly increased hepatic LDL receptor expression and increased hepatic uptake, clearance of cholesterol-rich lipoprotein remnants. One study found markedly increased hepatic LDL receptor expression together with a 128% increase in hepatic uptake of labeled cholesterol-rich remnants. I guess I haven't reviewed that specific that study, but that's at least it gives us some numbers. Apparently, the alpha klotho has by itself has the effect of increasing the receptors, but reflexively, the PCSK9 is also increased at the same time. And I think that's why there's a difference here, because the beta klotho, via a different mechanism, doesn't have that reflexive increase in the PCSK9 transcription. So this
Anything
one,
that will avoid giving statin, that will increase expression of LDL receptors, that will be great. But if it does not, then which is better, high Apo B or giving statin? Then you start thinking, okay, I'm going to give statin at this case. But again, you need to look at the root cause, because maybe the root cause is not because of LDL receptors, maybe because of the absorption. And then there is drugs that inhibit the absorption of the sterols. So we need to look at the root cause of the high ApoB, absorption, LDL receptor, excretion, diabetes, toxins. We need to look at inflammation. All of this needs to be screened out. And then you manage the root cause. You don't just give statin. But if you can give anything that will avoid us giving statin, I'm for it. But ApoB has to be low. Does that make sense? And then large LDL, and thank you very much, Dr. Yusuf, for all this innovative things. And I want you to start using it. There's a lot of patients out there with high ApoB, because nobody measured, by the way. Few of people, doctors are measuring ApoB. They have no clue about it in the beginning. So you can be looking at that ApoB thing, and then see how we can come up with some data that you are avoiding statin with other things, and also has to be economically sense for the patients as well.
and this is measurable by the mainstream labs.
Yeah, Apo B. Yeah, Dr. Stefan Hartman, he's doing it like a candy today for all his patients. And the idea about free buffet of fat needs to stop, because when you absorb too much of fat, you end up with high ApoB. So the idea of keto diet, free buffet, eat fat as much as you can, that needs to be stopped. And the optimal way of dieting is eating one meal a day, and it has to be mixed with less carb as much as you can, but 1 meal a day. That is the healthier thing. But keto diet and lunch and breakfast and all that, and still high fat, you will end up having problem because of the increased absorption of fat, that your eventually those chylomicrons, the liver will turn them into very low density lipoproteins and synthesis ApoB. And so that ideology of free buffet keto diet is wrong and needs to be fixed. That's why there's a lot of people against keto. And so there's some justification there. But at the same time, one will say if you eat fatty diet, it will help to get you the satiety that you need where you don't need to eat for the whole day. If that's the case, that's fine. But the purpose here is having one diet a day. Now, LDL, there's two part of it. There's large LDL and small LDL. The smaller it is, the problem it is. So the smaller dense, that means they can seep through the blood vessels and getting into the blood vessels and causing atherosclerosis. So the larger it is, the better. Those LDL particles, which contain Apo B. So if you have LDL, of course, all of them have Apo B, whether small or high or low density. But the small particle are more danger than the big particle. So if you want to measure Apo B and then you say, I want to measure those particle size of the LDL, whether it's small versus the large, then you're just adding more layer of investigating the risk of arteriosclerosis. But the more small, the better it is. So that's something you want to do it beyond Apo B, and you say you want to see the particles, the size of it, to see how much danger they are, and you can measure the small dense LDL particle versus the large in the lab. And then there's another one if you say I want to even measure more, but all of this may cost the patients, money. But if somebody wants to do it in terms of research, that's fine. You can measure something called lipoprotein A, which has Apo A in it, apoprotein A, and that's even more danger and more atherogenic when it has Apo A. And if it's high, that's mean you have high risk of atherosclerosis. So all of this is variables or tests. It just tells you the risk of atherogenic, but the management will be the same, right? Let's say they have high lipoprotein A, right? Then what you will do, we'll look at the root cause. Is it absorption? Is it clearance of the LDL from the LDL receptors? Is it excretion? Is it metabolic? So you need to find, and then based on the root cause, you come up with your management. You don't manage everything the same way. So the root cause laboratory, what you need to do when you start managing lipid in general, you measure Apo B, total cholesterol, LDL cholesterol. You measure high density lipoprotein, yes, and then you measure triglyceride. The non-HDL cholesterol means everything that's not HDL, which is the very low density, intermediate density, and low density lipoprotein. And you want to be more creative, you can measure the lipoprotein A. But if I want to make it easy, just measure Apo B and triglyceride. It gives you the best if you want to go with easy. Having
what
all of
about
this is fine too.
what about free T4, free T3, or just generalized T3, T4?
Oh, the thyroid you're talking
Yeah,
about?
yeah.
Yeah,
Because
you can go and do the T3, T4. The T3 and T4, the reverse T3, all of this just shows you there's inflammation there.
what I'm saying is, as I'm going through, I'm looking at everything I can think of, and then I went and searched for physiological thing, what we produce naturally that does do this, and T3, T4, estradiol does as well, but obviously, and that's good to know because if we were talking about bioidentical hormones, but definitely thyroid T3, T4. I mean that would, just knowing that alone, obviously we have to look at that deeper, but just knowing that alone would make me more apt to think in terms of suboptimal thyroid function and strengthening the case for, especially if I had the lab values showing that the APO levels are high, and
Right.
we had room for thyroid optimization. That's just one place that it would make me less hesitant to, even if the thyroid looked good, it would make me more likely to definitely want to consider adding T3 and T4, just in simple thinking.
Right. So any inflammation can cause mess up with those ionization of the T433 and reverse 33. So an inflammation itself, as a general, it can affect the thyroid, can affect the liver, and can affect the your lipid metabolism. It's because inflammation could be a secondary part of abnormal Apo B high. So, but again, if it's affecting the thyroid and thyroid is low, whether T3 is low, then yes, that could be a factor of increased expression of decreased expression of LDL receptors, and it could be secondary. So, looking at the kidney function, liver function, thyroid function, things that you do, six hormones as well, all of this needs to be considered because inflammation, oxidative stress can affect the whole thing. And toxins in your body have, those heavy metals, fungus infection, Lyme, everything that needs to be managed so that you don't have the secondary effect. You neutralize the secondary effect, including insulin resistance and diabetes, if any. So all of this needs to be measured. And all the family history. If they have history of heart attack, then you can consider there's genetics there, right? Not just insulin resistance. And so if there's any premature death, that's mean there's some genetic problems in lipid metabolism and atherosclerosis is not necessarily secondary. It could be genetic from the expression of LDL is low, family hypercholesterolemia, or it could be the absorption of fat too much when he eats. So all of this needs to be looked at. So we're going to do all this lab. And then we need to make sure we did the genetic roots. So after we do all those labs and all that stuff, and you want to know exactly, okay, so patients has problem genetically, they absorb too much of fat, especially the sterols. Then they need to go ahead and give medication that blocks it. Or the problem has with LDL receptors, then how I can give medication to increase the expression of LDL. Try not to give statin and use all the other drugs that increase the expression of LDL. And if not, then you use statin. Or the patient has insulin resistance, or fat patient has fatty liver, or patient has kidney problem, or thyroid. All of this needs to be fixed. And if it's genetics, as you see it here, then you need to go ahead and look at the root cause. Could be those LDL receptor, as you see it here. It could be because of absorption, right? And it could be, all those things needs to be looked at, and all those genetics needs to be looked at, or maybe their production. They produce too much of Apo B genetically. All of this needs to look at, and then we need to manage it based on the cause, right? So we need to confirm the phenotype, optimize the therapy, and also consider all those genetics. And those genetic tests is available there. You can order it, and you can know that there is a problem with the LDL clearance, or there's a problem with absorption, or there's a problem with the excretions. So all of these, you see it here, is the genetics that causing problem with in LDL receptors, right? LDL receptor here, or apolipoprotein B, defective Apo B protein receptor interaction, or the PCSK9, when they increase the expression of it, the LDL receptors goes down, right? Which helps, it causes degradation of the receptors when it increases the PCSK9. So we know what the drug that inhibit the PCSK9, statin is one, but there's other drugs that you mentioned can do that. And so we're looking for all those drugs that eventually will increase the clearance of the LDL receptors. And so, again, if the problem with overproduction because of insulin resistance and insulin itself, when you have insulin resistance, you have too much of triglyceride in the blood coming from the fat because your body cannot take sugar, so they stop breaking fat and they release triglyceride. Your liver say, oh, we have too much of triglyceride, need to pack them up. So they pack them up, leads to high, very low density lipoprotein in the blood containing Apo B, so you have a lot of cargo out there. And eventually you can see that you have left fatty liver. Fatty liver will decrease the excretion of the bile that leads to further accumulation of LDL. Apo B goes up, and you end up with atherosclerosis. Or you end up having problem with absorption and sterol disorder, which you have too much of absorption of fat. Then you need to consider how we block it. Well, there's drugs to do that, and there's a lab to measure the sterols. So how I can know the problem with absorption? Then you can do a blood test for sterols, and if it's high, right, then that is the problem. Then go ahead, give the drug that inhibits the absorption of sterols. And then it could be because of the clearance failure, which is LDL receptors expression is low. Then you need to give them something that increase the expression of the LDL receptors. It could be secondary, as I said. It could be thyroid, hyperthyroidism, problem with the kidney, problem with the liver. It could be because of medication. So all of this needs to be looked at. And if it's overproduction due to insulin resistance, we manage it by managing the diabetes, things that we do for diabetes. And if it does not work, and you still have a problem with LDL clearance, then you may introduce statin, or you use this drug. It's called ezetimibe or ezetimibe. The ezetimibe, it works also same like statin, but if it does not work, then you may need to combine with statin. But hopefully, we think that if you manage insulin resistance, everything will normalize. Most of the time they will normalize. But if not, then consider there's some genetic components there that leads to the increase of Apo B production, and then you need to consider that statin. So clearance failure, then you have to give them istimab, which blocks the PCSK9, or also you can give them statin as well. In those cases, if istimab does not do the work, or it could be absorption of sterols, and you can measure the sterols level, right? And the normal is low as 1 milligram per deciliter, and if it's above that, then you have problem of absorption. Then that's where you give them STMF 10 milligram to inhibit the absorption here. And then if there's problem with kidneys or thyroid, so you look at those secondary effects and you measure the T4, the T3, the TSH, and you look at all the secondary effect of it. So we need to keep the LDL Apo B less than 80, or some people they come up with less than 60. And it depends on the condition. Patient has too much of atherosclerosis, you really need to keep it less than 80. But we need to keep the triglyceride less than 150 as much as we can. And we need to work on your insulin sensitivity because that helps to also lower the Apo B. But if it takes drugs to inhibit the absorption, then go ahead and you give that. If it takes drugs to increase expression of LDL receptors, as we said, there's other peptides that Dr. Joseph is recommending here. Whatever it takes, just go and find out the root cause and do the genetics. And you can do the genetics and then use the AI. He will put it together and tell you, okay, the main problem here is insulin-driven high ApoB. The main problem here is the absorption and sterols. So advise the patient not to take any fat from seed extracted from the seeds. Those fatty acids or those oil extracted from the seeds, they contain high sterols, or you give them drugs that inhibit the absorption. You need to look at the root cause. You just give the statin to everybody. Patient may have fatty liver. Patient may have kidney problem. Patient may have hypothyroidism. Don't give statin for everybody. Look at the root cause, and based on the root cause, justify what needs to be first, second. Let the statin to be your last resort after exhausting all the tools that you have. If it takes to patient with obese above 300 kilogram, I'm okay with using GLP-1. But if you use GLP-1, you need to look at all the side effects of GLP-1 and navigate it. The side effects is muscle wasting, so you have to give them creatine. You have to give them all these things to increase the muscle. You have to put them in an exercise program. You just don't give GLP-1 without looking at deficiency of B12, deficiency of nutrition, amino acids. So you need to consider all the side effects and navigate it with a companion supplement pack that will navigate all the side effects of GLP-1. If it takes you to give them other diabetic drugs that helps to decrease absorption of sugar like acarbose, or inhibit or increase excretion of sugar. All of this, or inhibit absorption of sugar, all of this drugs, oral hypoglycemic, that's fine as long as you can manage the diabetic and increase the insulin sensitivity. There's nothing better than exercise. Exercise and increasing the muscle, it will increase the secretion of the clotho, and the clotho itself can increase the LDL receptors. Exercise can help in increasing the sensitivity of insulin by increasing the number of the receptors. So yes, and decreasing the fat as much as you can, because the fat is inflammatory, the storage of all the toxins. Get rid from that. And if all these things did not work, then maybe you want to start with ezetimibe, a 10 milligram, and if it doesn't work, then you may need to give statin. But again, if you give statin like GLP-1, you need to look at all the side effects of it, how you can navigate it, whether giving them CoQ10, you give them things just to lower the Apo B. So give them the minimum dose that you can. But don't start with statin as the first thing. Look at all the tools that you have, and if all fail, then you go to statin. No, I hope that in the future we will have a drug that has no side effects of statin and still can increase the LDL receptor expression. So estimab can be given to inhibit the absorption of the sterols. It can inhibit the cholesterol absorption. It also helped in increasing the LDL receptor expression. So I will definitely recommend Estimab 10 milligram orally once a day as a start, and maybe I will give statin after that if it doesn't work. And so Estimab doesn't have the absorption. If you have genetic problem with absorption of sterols, then Estimab will be enough. Maybe you don't need a statin. If their problem is problem with absorption, you have too much of absorption because of genetic errors there, absorption of sterols, then just give them Estimab, and there's a big chance that your Apo B will go down. All right. So do what it takes, and look at all this cause of the steatosteroidemia, which is increasing the sterols in the blood. And knowing the level of it, you can measure it and then use Estimab to decrease it. And there's genetic testing to know that you have a problem with absorption of excess of those fat or sterols. And so measure the sitosterol, the compisterol. If it's high, then you have high absorption of fat. Then just use Estimab to block it, and it has to be less than 1.1, right? If it's above that, then think about giving Estimab to inhibit the absorption of the fat, which is sterols will give you an indication that the patient is absorbing too much of fat. LDL receptors, again, the only thing we have, you can start with statin, or you want to start with Estimab and then start with statin, that's fine. But according to what's recommended here, statin, and then you add Estimab. And then there's other drugs that inhibit the PCSK9. Dr. Joseph said some Clotho. Here they say there's some Evo Locumb, 140 milligram. That's twice a week. Or Alirocumab. Those are difficult names. Maybe will help also to inhibit the PCSK9 activities, because that's the activities is degrading the LDL receptors. Anything that helps is a good thing. And maybe this will help, right? And whether you need to know the root cause, and eventually using all the tools that you have and try to keep statin at the end. So again, anything that suppress the PCSK9, and I need Dr. Joseph to start searching for all this FDA approved peptides or whatever, amloxanox and all that, and see. There's another RNA therapy, which is this antisense RNA that interfere with the production of the PCSK9 synthesis. If I can suppress it with this antisense RNA, that would be good. And I think those are under trials. I don't think it's FDA approved, but if it is, just go ahead and give it. The inclisiran, right? If you have a challenge with every tools that you have, to lower the Apo B, you may end up doing antisense RNA.
I can tell you, I can tell you what's being studied right now. Or I mean, what's being not just studied, but what they're testing as something to keep an eye out for is the actual fibroblastic growth factor 21. And in fact, I think they may actually have a synthetic version on available for, but I think it's in the research context. But what that means is obviously there's probably a peptide version, meaning the fragment version that actually stimulates the I forget what the name of it was that actually directly downregulates the PSK. Do we know what those actually stand for? Or are they just laboratory synonyms
No,
or
it's an expression of a
abbreviations?
protein. It's
So I
a
mean the actual name of
I don't know
these.
the acronym of it. It's an
Okay.
acronym for a big name, yeah. But anything you can come up with and you try it with the patient and you avoid giving statin, that will be good. And it has to have less side effects than statin. Otherwise, if you have more side effects, then it defeats the purpose. And everything that you have to look at all the secondaries: diabetes, kidney disease, nephrotic, hypothyroidism, medications. Like we have less of medications that can lead to increase the ApoB, the thiazide, beta blocker, cortisone, cyclosporin, anabolics. So all those medications need to be listed, because if the patient is taking anabolic and he has high ApoB and they say, oh, you know what? Well, because of let's go ahead. We have no answer for it, and the patient's taking up anabolic and too much or something like that. So all of this needs to be looked at, all the drugs, so that we don't need to give harmful drug to the patients, and we can exclude those things that leads to the increased ApoB as a secondary cause. And then very important that all of the treatment that we talked about, whether inhibiting the absorption of the fat or increasing expression of LDL receptors, or inhibit looking at all the things that interfere with these excretions, including liver failure or nephrotics and disease of the kidney, or hypothyroidism, all the secondary causes, they will not fix what's already been done. If you have atherosclerosis already with fatty plaque, fibrosis, EDTA, you cannot really say I'm going to reverse it just by, you can prevent adding on it, slow the progression of atherosclerosis by lowering the ApoB. But if there is already atherosclerosis there, it's going to be very difficult to reverse it there. And so one way you can do with exercise, increasing blood vessels, to bypass those atherosclerotic blood vessels, the old ones. Yes, and exercise can increase the flow, and possibly it will help to loosen up the blood vessels of fibrosis. Yes, and but still, possibly you need to something that to dig in and get the fat out. Cyclodextrin is the answer, and cyclodextrin, if you see it, it's almost similar to what high density lipoprotein. They are trash truck that collect all this bad cholesterol and dump them back into the liver. And we can increase it by exercise as well. But if it's not enough, then you may need to consider giving the patient cyclodextrin. And we have a pharmacy, Mike Emmanuel, can help you, whether it's oral or suppository. So that's something you can use it to lower. And then we have cases. Let's say we have case 52 years old. Triglyceride here is high because it's low, above 150. ApoB, it's 125. So we can consider it's high. High density lipoprotein, it's low. Hemoglobin A1C is very clear. The patient has diabetic, fasting insulin elevated, fatty liver, and he has high triglyceride, very clear, because triglyceride HDL ratio is high. And so the patient has insulin resistance, and he has ApoB overproduction. What do you think about this? Most of the time, they are insulin resistant, driven high ApoB. And fix the insulin resistance. You don't need to give statin in the beginning. Just fix insulin resistance, and his ApoB will drop. Now, again, Stefan will challenge that and say, well, I have cases and all that stuff. Yes, there's some cases where you have combined. Could be insulin resistance plus he has a genetic abnormal with absorption of steroids. Or he has problem with genetic with LDL receptors, right? So basically, there is a way that we can say people have. You cannot just go ahead and say uh, absolute. If it's high triglyceride and high Apo B, that means insulin resistance, and that's it. In medicine, there's some exclusion there. But let's say if the patient has high Apo B, like this case, the second one, and then normal triglyceride, most of the time, this is not insulin resistance. Why? Because it doesn't make any sense. How the triglyceride is low, because if you have insulin resistance, then you have problem with um, you have problem with consuming or using oxygen, glucose. Then you need to get the fat. How are you going to get it? You get it from the fat tissue. So that's mean you're going to have release of triglyceride in the blood. So it has to have high triglyceride. So if you have normal triglyceride and you have high Apo B, then this is mainly could be genetic, or it could be environment, other factors, secondary. It could be secondary due to other reasons, but mostly it's genetics. And we need to screen the genetics, knowing where is it because of the high absorption or problem with clearance, and that's where we need to dig. And that's where we need to use, STMEP if they have problem with absorption, and possibly we use statin after you consume everything else. Now we're gonna build the protocol that is non-statin protocol as much as we can. Me and Dr. Jusuf, we're gonna work on it. But and I know that Stefan Hartman is taking statin or recommending statin for patients. But if there is anything that we can do without statin, that would be great. I don't know if he's here or not, Stefan. Um, so that would be
Why not
master
just use
clinical.
why not just use Repatha instead of the statins, because it's much safer for your
What
neurons and
what you will use?
mitochondria.
Sorry.
A Repatha, like a PCSK9 inhibitor.
Yes, you can use those ones, but still, if it does not work and you still have high Apo B, then you may consider statin. I say this is the last thing you consider statin. But if you can use all the tools and you normalize Apo B, you don't need a statin. Dr. Joseph said, Clotho, possibly amloxanox. We're going to figure it out, come up with a protocol that's non-statin that increases enough of the receptors without using a statin. But the first thing you need to confirm the particle burden. So the first thing we do here is to measure the ApoB and do the lipid profile in general, including triglyceride. And then we need to look at the overproduction of it. Is it because of absorption of because of sterols? So we measure the sterols to see it's a problem with absorption, or it could be because of clearance defect, and that's why the LDL is high. So genetic testing can tell you that, or it could be secondary causes because of diabetes, insulin driven. So I start with insulin driven. Look at it. Okay, if they have fasting insulin is high, then yeah, that's more of insulin driven. So let's go ahead, especially triglyceride is high, let's fix that. But if not, then we need to look at whether it's because of absorption or clearance, or it could be because of other secondaries, as we talked about, the liver, the kidneys, and the thyroid, right? All of this needs to be checked, and making sure we clear up the secondary. And we may need to do genetic testing to really clear that, the problem was absorption, because we have high sterols, plus we have genetic clear that there's an absorption problem, or there's problem with genetics in the clearance, not the absorption. And then we start fixing it by lifestyle. If it's secondary due to diabetes, we fix that. And then we try to do everything without, and let the LDL will be the last thing, including giving STMEP or those PCSK direct therapies that we talked about. But you need to be creative there as much as you can, and then make sure that the drugs that you're going to give it does not have the side effects that is way ahead of the of statin. And then you need to monitor all of that and reassess and see if you reach the goal, which is lowering ApoB and lowering the triglyceride. And So again, it's not about lowering the number. It's looking at the content of the patient, looking at everything. Inflammation could be the cause of it. Diabetes could be Lyme disease, could be all of this. It could be lower sex hormones. If you have lower sex hormones, that can cause inflammation, oxidative stress, and it can lead to LDL receptors to be decreased as well. So all of this needs to be optimized. The patient's health, the weight needs to be optimized. And we talked about that a lot of blood pressure patients, they consider it as primary, but the fact they are secondary due to high insulin. Insulin is vasoconstrictor. And we wrote a book on that most of those primary, so-called 90%, most of them are insulin resistance because nobody measured the fasting insulin for patient with hypertension. None. And then they start giving them all this hypertensive medications. The same thing here. We need to look at all the root cause and neutralize it and optimize the health in general, including sex hormone, including detoxing, including leaky gut, including everything that you have to take the complete data from the patient, history, physical, all the data, genetics, all the lab tests that we think it's important. Of course, you don't just shoot in the dark and do all the labs. It has to be focused based on history and physical. And so that can be efficient and effective, not, just doing all this expensive lab and it become an expensive and it's worthless. Medicine and practicing medicine, it's not just efficacy, it's the efficiency as well. So if you don't put the economic part of it, then you're not practicing medicine. You're kind of practicing, maybe people with high income, they pay everything, but that's not reality. So medicine has to be efficient and effective. So again, what about the blood vessels that already have atherosclerosis? You cannot just say, I'm going to manage them with manage insulin resistance or normalizing thyroid or giving them statin or inhibitor of those PC thing. No, actually, you need to look at way to get the cholesterol out of those blood vessels, and the only way you can do it with cyclodextrin, along with chelations, EDTA to get the calcium out, and along with antifibrotics, anything that helps to break down the fibrosis. Clotho is one. Statin and losartan, especially if it has high blood pressure. I don't know about normotensive people. You want to use lower dose, but we don't have much of data, although the mechanism makes sense. But you can use bromelain, although we don't have much of data, but lumbokinase to lean up or get those blood vessels more flexible. And the best thing is exercise, building up new blood vessels and just bypassing those old blood vessels. So cyclodextrin is a drug of a choice. You can use orally or substitutory. In Australia, they have it, and we have a compounding pharmacy who can do it for you, which we spoke in the beginning. We train him how to do it, and he can do it. Plus, cyclodextrin is a good delivery drug or agent, like a cargo to deliver drugs. Using sonication nanofiltration, we can deliver a lot of things, drugs, supplement, peptides with cyclodextrin. And so it's like two birds with one stone. It's delivering drugs, plus it helps to clear up all this dust of fat, and especially oxidized fat. So cyclodextrin, it's well recognized in Australia as a detox for cholesterol of the plaques, of managing of atherosclerosis, and they have a company who's producing it. I don't know yet, it's being cleared by FDA, but it's being cleared by FDA, drugs loaded with cyclodextrin. We have a list of drugs that is loaded by cyclodextrin as a delivery, and it helps to absorb those fat-soluble drugs to be absorbed and getting into the body, and better pharmacokinetics. So cyclodextrin is being used as a delivery agent, and it's FDA approved with many drugs. And it also helps to clear the plaques. In Australia, they have a supplement for that. Again, the Apo B pathophysiology, lipid metabolism and therapy. If you see, this is a complete map about the whole metabolism of lipids. and all the disorder, whether absorption or clearance or excretion, secondary or primary from genetics, secondary from diabetes, or secondary from liver, or secondary from thyroid or kidney. All of this needs to be checked. Or sex hormone, by the way. Sex hormone, if it's low, it can lead to increase the Apo B. So all of this needs to be considered. So if patient has low sex hormone and high Apo B, the problem with the sex hormone is to go up. But some people, they cannot take sex hormone because they have prostate hypertrophy. Then they need to go ahead and manage that prostate hypertrophy by doing some sort of embolization, embolizing it. That's the best way, or using all the technique to reduce the prostate so they can resume taking their sex hormone. So I think we are done with the lecture. I don't know how many people left, but we start with 15, we end up with 9. That's a good retention. Kind of more than quarter, more than 75%. So any questions?
Yeah, this is actually a more significant lecture than I initially thought, and it's because basically what we're trying to do is we're trying to treat fatty liver disease. Anything that decreases the Apo B, I think, and increases the LDL receptor is also affecting the fatty liver disease in general. Now, that's what I think. And there's a phase 2 trial for something called Intrigue, and this is actually a fibroblastic growth factor 21 analog. And I think that's how they're attacking this whole thing, because that's just one step away from the that PSCK uh, receptor, or that expression, downregulating that one step above it. And this FGF21, I guess, it has such a short half-life, and that's why they created an analog. It's in a phase 2 trial, and so far in 8 weeks they showed that ApoB reduced by 10.5%, and the non-HDLC, I guess that was decreased by 18.3%. Triglycerides decreased by 57.3%. So they're actually doing it for hypertriglyceridemia. ApoC dash 3, or is it 111, decreased 41.9%. ApoB48 as much as decreased by 73%. And the LDL-C minimal overall change, so it's not acting directly on LDL. The ApoB reduction was statistically significant. P equals 0.019. And why ApoB was falling without much LDL-C reduction matters. And I guess if LDL-C equals the amount of cholesterol contained within the LDL particles, whereas ApoB sort of approximately equals the number of circulating atherogenic particles, because essentially every VLDL, intermediate IDL, LDL particle carries one ApoB100 molecule. So the results suggest that FGF21 signaling isn't merely removing cholesterol from LDL particles. It appears to be changing lipoprotein particle production and clearance. Okay, so it's all about the clearance. An extraordinary 73% reduction in ApoB48 at the weekly dose, and ApoB48 represents intestinally derived chylomicrons and their remnants. The investigators specifically interpret this as evidence of enhanced clearance of chylomicron remnant particles, in addition to reductions in ApoB100 containing particles. So it's giving, says here, that gives us potentially several simultaneous mechanisms, including FGF21, in regards to FGF receptor 1C beta klotho. So it's the same basically it's the same mechanism, and maybe there's an additional. Put it like this: it strengthens the beta-klotho connection considerably, and at the same time, it says the Apo B reduction isn't enormous compared with the PCSK9 inhibitor, but mechanistically it's impressive because FGF21 is attacking the metabolic production remnant clearance system rather than just simply blocking LDL receptor destruction. Um, and I asked, when is this going to be available? I mean, just so that we know. Obviously, we have to do everything else, I understand. So possibly in a year, more likely entering 2028. So in looking at this, this is like literally affecting steatosis, inflammation, fibrosis, insulin resistance, and dyslipidemia simultaneously.
Right.
Yeah, so think about it. What they're basically saying is a treatment for fatty liver disease.
Yeah, anything that helps the fatty liver help to um, prevent the stagnation of the bile, help to get rid from all this extra fat in the body, right? Because that's the excretion part. Um, what I find this is good, the statin actually increased the expression of PCSK9. So, but it inhibits the cholesterol. Um, so try not to give statin as much as you can. And the reason they give the estinib, it helps to those inhibitors of PCSK9. It helps to negate the the increased expression by the statin. But statin, how it works is by lowering the production of cholesterol. Again, I will recommend not to give statin as much as you can and use everything else. And then if everything else fail, then try the statin if it does help to lower the Apo B. And all you need is lowering the Apo B. I don't care about the total cholesterol. But most of the time you achieve that without the need of statin at the end of the day. There's a lot of supplement that lower the PCSK9, berberine, curcumin, quercetin, resveratrol, ACGC, omega-3. Avoiding taking any plant seed oil that contain high sterols. And again, those PC estimate, for example, and all the drugs that inhibit this PCSK9 can be given as well. But those are supplements, and possibly there will be some peptides. One of them is called anilictide or anilicetide. It's a peptide that inhibit the PCSK9, and Dr. Joseph mentioned some of them out there. But this is actually the peptide is called enclicitide. Deconicate is another peptide there. So enclisiran, another one, which is Licrio or Licvio is a drug. So there's many agents out there that inhibit and so we may not need to give a statin. Again, statin is the last thing you give to the patient if all the tools you have is being exhausted. So that's my recommendation today, because statin has a lot of side effects. Interfere with mitochondria, it damages the muscles, it damages the eye, and you really want to avoid it and use everything else that we talked about. And try to optimize the body in general, because inflammation, whether coming from toxins or heavy metals, or coming from leaky gut, or coming from chronic infection, or all this inflammation coming from low sex hormones. So you need to optimize the body as much as you can and do whatever it takes and use all the drugs that has minimum side effects than statin in lowering the Apo B. But Apo B needs to be low. And again, cyclodextrin needs to be used, because even if you lower the Apo B, it does not mean that you are reversing the atherosclerosis itself. So whatever is being built there of plaques and fat and fibrosis and calcium, all of this you need to look at other agents to make sure you dig into those blood vessels and you clear them. And the last thing you think about stents, and if we have this kind of campaign for prevention, we may end up stopping the need of stents. Especially now we know the root cause of abnormal lipid metabolism. We have better now to prevent patients from having atherosclerosis itself, because once you have it and your 70% of blood vessels being blocked, then it's just hard to reverse it. And so prevention, and looking for the drivers of the pathology and manage that versus treating the disease itself. Any other questions? Dr. Juicer, thank you for all your contribution here. Everybody's happy? Anybody in the text is writing something?
Great lecture.
Okay,
great topic.
anybody?
Yeah, no, just great topic, because that really is something that is not being looked at. I mean, as far as I know, and typically I always thought of the genetic tests and looking at those, predispositions, but not actually measuring the actual Apo B, and sounds like that really gives a marker as for how congested the liver is, perhaps that and other things. And my biggest thing is, it's going to sound abstract, and what is abstract is maintaining consciousness. Okay, because the things I talk about, I did a lecture on initiation gating dysfunction, and this idea that there's an epidemic of what looks like procrastination, or people telling me, including myself experiencing it, and people that are not necessarily just in a niche patient crowd that I see saying a similar thing, like I have difficulty initiating things, like it takes me longer to get ready in the morning, or I know what I need to do, but I can't seem to get as much done during the day. The day is over before I start to do some of the simple things I used to do all the time. Well, that's the result of brain inflammation of the basal ganglia. And there is, I don't have the exact mechanism, but that is going to worsen towards worsening of mental function, neurodegenerative disease. There seems to be a connection between the ApoB levels and especially some of the genetic predisposition. So if that isn't being addressed, you're doing all the things and you're not aware that that is working behind the scenes to, further build up tau proteins, or allowing tau proteins, making it more difficult to clear them from the brain, then we are just going to continually lose brain function. And I'm not saying everybody is losing. Well, I do think there is a generalized, I can imagine, it's not a proven thing, there is a slowing down. But what is well documented or well spoken of in the literature is an increased rate of dementia and Parkinson's in younger and younger people. And to me, that's the worst tragedy. And consciousness at the end of the day is the thing that I'm most concerned about retaining, optimizing. I don't want to lose consciousness. That if I had to boil it down to one thing, it's consciousness. And so that's where I'm coming from with this. And sounds like we've become unconscious tonight. So I guess if anybody else has any other questions, are we done?
Boy, that neuroinflammation and neurodegeneration has certainly accelerated after they unleashed all those COVID mRNA injections on everybody, I'll have to say.
Right? Exactly. All of this stuff is causing, increased damage to the endothelium, and there's then more endothelial dysfunction, and then more. I mean, so many people they don't have to have myalgic encephalitis, chronic fatigue syndrome as a dominating their situation, but word finding. I mean that's epidemic. I mean, I come across that all the time. Or people will finally admit that they're having some issues with that, or why do they not want to read? Why is the attention span declining? All that stuff points towards all of the things I just said, as I guess we could just call it a thought experiment, just to, keep it more professional. But yeah, I mean, it all makes sense. And then you throw on there your particular phenotype, each person's particular phenotype. And if we don't know those predispositions, perhaps these things are strengths in one context, but in this context, they can be crippling. And so somebody that has all the things going for them mentally, maybe they're an intellectual by nature, they're good at logic, they're good at abstract thinking and science at the same time, they may be at more risk than the average person. And if they don't know about these other aspects, things that are measurable, so that they can keep kind of know where they stand. Because it's hard to know where you stand mentally. I mean, when you think about it, does somebody necessarily know when they're slipping into early dementia?
I don't think so.
Right?
I don't think they do.
Exactly. They just think that I'm just slowing down. I've become more spiritual, or,
I'm getting older, old
I'm
timer.
just getting, I'm just getting older.
Yep.
Exactly. Well, I just don't want the same things. Why don't you want the same things? Is it that
Right.
the hormones that you're producing are dropping, the dopamine production, the reward centers are,
Yep.
declining faster than they should be?
Well, it was funny you were talking about the word retention. I pretty much all but lost the ability to spell. My spelling words that I used to be able to spell no problem, just I lose it. I absolutely lose it. It's weird.
Yeah, exactly. Exactly. This words, yeah, there's a lot of words where I'm like, wait a minute, I know how to spell this, but I just can't,
Right.
and it doesn't have to be like